Every Voice Speaks unites and empowers the muscular dystrophy community by elevating patient voices and fostering collaboration across conditions like LGMD, FSHD, myotonic, Becker, and Duchenne. Through personal stories, expert interviews, and accessible discussions, the show helps listeners understand drug development and learn how their input can influence trials, policies, and care. By centering lived experience, it strengthens advocacy, advances research, and supports better futures for kids and adults living with muscular dystrophy. Welcome to Every Voice Speaks. Today we're talking about something that sounds technical, patient-centered design, but is really about something very human, how adult muscular dystrophy clinics are built around the people they serve, not the other way around. We're going to talk today with two adults living with muscular dystrophy, Becker and limb-girdle 2A, and from the director of an adult multidisciplinary clinic, Dr. Nicholas Johnson from Virginia. Together, they'll walk us through what a clinic visit feels like, what's working, what could be improved, and what ideal care might look like in the next decade. In addition to being individuals living with Becker and limb-girdle, you're going to hear some thoughts and opinions from across the spectrum of a bunch of adult neuromuscular diseases. I'd like to turn it over now to our host, Kat. Hi, Kat.
Hi, everyone. It's so good to be here with each of you. So today's episode is really exciting to me. It's about multidisciplinary clinics. I just want to make a shout out to MDA because this was kind of their brainchild years ago to provide this multidisciplinary care experience to adults. And so as an individual living with limb-girdle muscular dystrophy, it's really important to me that we really enhance this whole system and that it really is patient-centered. So I want to just describe just a moment before we meet all of our guests. Today's podcast is really about what a patient-centered multidisciplinary clinic would look like for muscular dystrophy patients. So if you go into the clinic and you're going to see your neurologist, the ideal scenario would be that you would also be able to see other specialists within the same day, or the appointments would be coordinated for you within that day or the next day. And that just is to ease the burden on patients. And so today we're talking about all of this. And we're also going to be introducing the fact that we're starting LGMD centers of excellence. And Dr. Johnson's center is going to be the hub along with 4 other centers as well. So before we get to all of that, I want us to meet all of our guests today. We have Nevin Steiner, who lives with Becker, MD. Nevin, do you mind sharing a little bit and saying hey to everyone?
Hi, everyone. I'm Nevin. I'm 42 years old, and I live in Connecticut with my wife and 2 kids. I'm currently at a pediatric center that still sees adults at UMass in Worcester. So I am very interested in figuring out how to come up with the adult comprehensive care centers for muscular dystrophy.
Thanks, Nevin. And then we also have Carol Abraham, who lives with limb-girdle muscular dystrophy, and she also leads an LGMD foundation as well. Carol, would you like to just say a few words?
Sure. I appreciate the opportunity to join you today. I'm Carol Abraham, and I live in Wisconsin. I am the founder of LGMD Awareness Foundation, and I'm 65 years old, and I live in southeast Wisconsin. So for my medical care, I am seen through the Medical College of Wisconsin Frederick Hospital, which provides a multidisciplinary setting for all of my adult care.
Okay, great. And then we also have Dr. Nick Johnson on, and he is at Virginia Commonwealth University and leads GRASP LGMD, and he's the director of the Center there for Inherited Diseases for Muscular Dystrophy. And Dr. Johnson, would you like to share a little bit?
Yeah, it's thanks for having me on. I'm excited to talk about our multidisciplinary clinic. As Kat said, we're in Richmond, Virginia. We see both adults and kids with muscular dystrophies and other genetic nerve and muscle disorders. And I've been in this line of work for about 12 years now.
Thank you, Dr. Johnson, for taking the time and being with us. And so I wanted to start, Nevin, with you. And just will you share a little bit about your journey with Becker? And you had mentioned a little bit, about your diagnosis earlier, but what has your life looked like with Becker, and how has that journey been for you with your medical care? And then you mentioned you were at pediatric clinic, and I think that happens a lot for the adult community, as the pediatric clinics are so good that a lot of us are like, don't make me leave. So I want to hear a little bit from you first.
So I was diagnosed at a very young age. I was 6 years old. And as I tell people a lot, it was like climbing a mountain and then going back down the mountain. As I grew and got older and my muscles developed, I had skills to participate in, all activities as a kid. Got to the point where, I was doing long distance bike riding and playing tennis. And, one day, all of a sudden, I didn't have those skills anymore, and it was quickly going down that mountain. Where I am today, I'm not fully in a chair. I have a rollator, which is a four-wheel version of a walker that I use on a daily basis to prevent falls. Throughout this process, though, I was always in comprehensive care from a young age, to the point where when I went to college, I went to a school in Baltimore, and I immediately went to Johns Hopkins for my care while I was down there, and I was independently doing that on my own at the age of 18 and 19. So my desire for comprehensive care developed at a young age. I was in Kennedy Krieger in Baltimore for a long time because of going to school down there, so I would travel down there. But when I had my family and I'm in Connecticut, I decided that's not going to work to go to Baltimore if it's going to be twice a year, or if it's even more than that. So I had to transition to care in Connecticut, and I went to Yale New Haven, and it was good, but it was a multidisciplinary clinic. They saw people of all neuromuscular diseases, and I was doing a lot of the directing of what I needed in my care. So I found my way to UMass in Worcester. I was asked to participate in a trial, and then I saw the doctor up there, and it's, primarily pediatrics, but they still see adults, which is great. And everything is in one roof. I currently am a little bit all over the place just because I have histories with different specialists. So I've stayed with, the special cardiologist and the pulmonologist, but I go to the neurologist there. But what I like about the place is if I wanted to do it all in one spot, the X-rays, the blood, the bone density, the neurologist, the nutrition, the exercise, the pulmonology, the cardiology, it's all there. And throughout this process, the one thing that always sticks to mind is when people tell me I've had to leave my location because now I'm adult and they only see pediatrics. Well, the conditions that 12-year-old with Duchenne has and 42 with Becker are very similar. So I'm a proponent for everything staying together. It doesn't matter what age, because the care we need is all the same.
Wow, what a great point you made. I know we're kind of forcing all of the muscular dystrophy clinics into this scenario where they have, the pediatric population and then this adult population. And then, you know, we can't let one of those be sacrificed. So putting everybody together so that everyone can get the care it's an important aspect of what you just said. And I think when we talk about this multidisciplinary care, the model has to be equitable for everyone, but it also has to be scalable so that the clinics can actually provide this service for not just one population, but for others. And we know that with healthcare, the clinics are really under resourced, and they need our help as well. And Dr. Johnson's going to talk about that in a little bit. But I want to also pivot to Pat, because I know he wants to talk with Carol Abraham as well about this.
Yeah, so thank you, Nevin, and all important points so far. So, Carol, different area of the country. Tell us a little bit about your diagnosis path and challenges that you face in multidisciplinary clinical care?
My symptoms began also around a similar age. I was 5. I was a toe walker, and my mother was concerned. She was a nurse for an orthopedic surgeon, so went to the doctor, and at first I thought, "Oh, gee, kids walk on their toes, maybe she'll outgrow it." Well, by the time I was 9, um, I was walking on my toes and could no longer get my heels on the ground. My parents noticed that I was having difficulty keeping up with my peers, struggling to get up from the ground to a standing position. So, Pat, after listening to your podcast last week, I think you and I had a similar experience.
Mm.
Um, at the age of 9, I was actually admitted into the hospital for a week for diagnostic testing to try and figure out what was the cause of my toe walking and my weakness. Had a muscle biopsy, had numerous PT sessions and lab work and so forth.
Yep.
They did a muscle biopsy. It was inconclusive, but basically based on my clinical presentation at the age of 9, I was diagnosed with LGMD. At that period of time, back in the late 60s, um, that was the diagnosis, LGMD. There were no subtypes. It wasn't until the age of 50 when my neurologist recommended genetic testing. And so I did the genetic testing through blood work at the age of 50, and that's when I received the diagnosis of LGMD2A, or now referred to as R1.
I think it's cool that the patients on this call, we've been blessed to be around long enough that the technology has caught up to our bodies to an extent where it can be 100% confirmed genetic diagnosis. But that's a whole nother show. What has your adult care, Carol, looked like? Do you also deal with a multidisciplinary model, kind of like we're going to hear
Um,
from Dr. Johnson, or do you?
my care, I really did not see many medical professionals when I was a child. It pretty much was my primary care doctor, an orthopedic surgeon, the one my mother worked for, and then the neurologist who diagnosed me. It wasn't until I was in my early 20s that I um, realized that I needed to see some more professionals. And I live in a small community, small local rural hospitals and so forth. So that's when I pursued going up to Medical College of Wisconsin, Frederick Hospital, for my multidisciplinary care. And I have been with them now for the last 40 plus years. I've got
Wow,
quite a,
40.
yeah, I
Wow.
started there when I was in my early 20s and I'm 65. Um, so, yes, I've got a very well developed team there. I see neurology, orthopedics, pulmonology, PT, physical medicine and rehab, GI. It really is quite a team that I work with, and I'm so appreciative of the coordinated care that I get. I really feel like I'm working with a team, whether I'm being admitted or what. I know that my team is coordinated. They're working together. Um, to make sure that I've got the best care possible.
I I I think that is outstanding. And for those of you that may be listening that are not so familiar with the condition, when we talk about clinic visits, because muscular dystrophy encompasses so many systems in our body, not just muscle, we require to see as we get older cardiology, neurology, They want to check our bone health. We have to deal with pulmonology. We have to deal with gastrointestinal issues and a whole host of other things while we all have to we are still adults. So we have jobs and careers and families. So getting everything together in one roof within a 1 or 2 day visit is obviously a huge, uh, if we can find it. So with that in mind, our clinicals are not just a medical stop like getting a physical. We have very in-depth challenges that need to be monitored throughout our lifespan. So, Kat, I know that we're going to discuss with Dr. Johnson here about what that might look like.
Yeah. So, yeah, we can get into that right now. So, Dr. Johnson, from a clinician's perspective, I think it's important, when we talk about these multidisciplinary clinics, that we hear your perspective as a clinician.
Yeah, I mean, I think that the muscular dystrophies are complicated conditions, and unfortunately, they're rare. And so, these MDA clinics that were established now, I think 20, 30 years ago, if not more, in some parts of the parts of the country, provide, kind of a tentpole experience for patients living with these conditions, where we're able to provide not just the neurological care, but also physical therapists, occupational therapists, speech therapists, respiratory therapists, cardiologists, social workers, dietitians, really to, deal with a number of the issues that come with these conditions. We know, for example, in Duchenne, that simply following, rigorous, well-established standard of care guidelines has increased the lifespan by at least 10 years without any other drugs involved. And so, there's no reason to believe that the limb-girdle muscular dystrophies are any different. And so, I think it's important that you have that specialty expertise that's available. Now, the challenge with these conditions, of course, is that there's not an MDA clinic oftentimes down the street from you. Unfortunately, these tend to be focused really in large academic medical centers. You need to have somebody that has taken an interest in the muscular dystrophies and be able to aggregate those other ancillary services into one roof. And then, the really challenge is that typically, for example, in our clinic, the only person that quote bills for the services is the neurologist. So the care that's provided by the physical therapist, speech therapist, et cetera, is got to be supported by somebody. And so I think the clinic director is also responsible for maintaining the finances of that clinic as well. But these are important experiences, and we think that rigorous, multidisciplinary care really does not only improve the quality of life, but frankly, it extends life for individuals living with muscular dystrophy.
Wow, that's such a great point. The extension of your life because you get those services. And I think when we talk about this, I think a lot of patients are hodgepodging things. They're going over here for this service, there for this particular specialty, and none of the specialists are actually communicating. And so, as we started to look at this more closely, as someone who lives with limb girdle muscular dystrophy and leads the Speak Foundation, which is the voice for patients, is basically what our nonprofit's whole ethical standard is about, is helping the patient have a voice. We wanted to start, looking at where we could improve the system for care across the muscular dystrophies. And Dr. Johnson, as I started talking with you and Dr. Peter Kang about the resources for clinics, we often understand that the clinics are operating on a shoestring budget as well. Is that correct?
Yeah, I think as I alluded to, it's really the clinic director's responsibility to provide the support for these, often quite long, like 4-hour visits. And many, for example, in our clinic, you might see 6 different providers. I think unfortunately in our healthcare system, the reimbursement for a neurology visit does not cover the near the cost of that a visit to the health system. Like it or not, I think that's the fact of the matter. And so one of the real challenges is maintaining these clinics in a sustainable way so that we're not, either cutting services, reducing the number of our visits. And then, just to be honest, every minute that the clinic director is out there trying to find new funding for their clinic is, that's one less patient they're able to see or something else they're not able to do to provide direct patient care. And so, providing sustainable funding for these clinics is an important issue.
Absolutely. Absolutely. So when we talked about developing the LGMD centers of excellence, one of the things that we wanted to make sure is that we provided funding to the clinics as part of this program. And the reason why we wanted to make sure is because we understand that the clinics really do need the resources. So, one of the hallmarks that we created with this infrastructure is something called an LGMD care coordinator. So I wanted to talk with you about that, Dr. Johnson. So let's walk through what that would look like. So patient needs to contact the clinic. Generally, in most cases, they're going to call the clinic number for appointments and scheduling. But for the LGMD centers, we've created a streamlined process for patients. So talk about that for a second and what that would look like.
Yeah, I mean, I don't know how many of you tried to call your local hospital recently, but you may have been surprised to be on hold for upwards of 10 minutes or more. No different at our institution. It's just, these are very large systems. They have facilities all across. And so it's hard to actually get somebody on the phone. And so the LGMD care coordinator provides that, direct point of contact, both for that initial referral, but then frankly, you know, the hope and the goal, for this care coordination aspect of it is that, that person gets to know you, knows your needs, knows what you do you want an early appointment, late appointment. And so they're able to help facilitate your care both at that visit, but frankly, I think this came up earlier, help kind of aggregate care if it's divided across different facilities as well. So really, your partner in crime in terms of helping you navigate your health system.
Yeah, that's to me like it's like the secret sauce that's missing that everyone would love to have in place and not just LGMD, but I could see this for Becker myotonic and other muscular dystrophies. And you and I talked about this, Dr. Johnson, about a scalable system too, because I think when other muscular dystrophies hear LGMDs have a center of excellence, everyone's going to be like, well, we want one too. And all that's great, but all of these systems need one thing, and that is patient-centered design. And what makes, I think, this scalable system work is that it doesn't overburden the clinic, and it also provides what the patients are saying they need. So truly often I see things that are created and they're saying that they're patient centered, but then you don't see any patients that are involved in the process. And so I think for this, it kind of hits, it's a win win for the clinic and it's a win for the patients as well. And I think that's, what makes this an ideal system. And Dr. Johnson, what you had mentioned earlier that, the care and coordination often looks similar across muscular dystrophies with just a few tweaks, right?
Yeah, I mean, I think regardless if it's limb-girdle muscular dystrophy, Duchenne, myotonic dystrophy, FSHD, everybody needs to see a physical therapist. Everybody needs, has often has some needs for assistive devices, respiratory support, speech and swallowing, et cetera. And so, at its core, clinical care across dystrophies is not very different. And so I think one of the things that I would love to see happen is to see these resources pooled together to really create a sustainable model with a focus on quality. Because I think the other thing that I sometimes see is say, well, we're going to make you a center of excellence, fill out this big application, which again takes time, but there's no funding or resources to help support maintain that high quality of care. And so I think the combination of tying quality to the support that's received pushes us all to reach the same shared goal, which is better quality care, that's provided a centralized resource in a sustainable manner.
Yeah, I totally agree. It's the financial underpinnings that the clinics really need to provide this excellent care. And I that's why I was really adamant that we bring the financial resources to the LGMD centers of excellence so that it's sustainable over years. It's great if you have it for 1 year, but what happens in year 2 and year 3, right?
That's right. Yeah, I think, then you see people, spending time, like I said, trying to find support for things that, they should be common sense for, I think, everybody on this call and people who've received care. You want to be able to see the physical therapist at the same time that you see the physician, for example, and receive that care all in one place. It's hard to go, and I think most people would prefer not to spend most of their lives going from doctor to doctor. You want to get out there and do other things. So, concentrating that care into a single day or half day, you know, provides the ability for people to live their lives outside of their muscular dystrophy.
That's so true. And I'm so excited about this whole concept. And we are excited to be able to partner with VCU and all these other clinics. I also wanted to just, make a shout out too for Carol here, and her foundation is going to become part of being a supportive partner. So she and her foundation wants to actually support LGMD centers. And so I just wanted to make a shout out there. And as we continue to talk through all of these exciting uh, things that we're going to do for the patient community, I just want to say thank you, Dr. Johnson, for everything that you do, and we are just so grateful. You are an excellent neurologist. And my heart is in Richmond, Virginia, because I grew up and I was a part of VCU's neurology clinic as a kid. So, I just kind of have those tender feelings for VCU always. And I want to say thank you so much for what you do.
I appreciate that. We're definitely in this together.
For sure. Thank you. And thank you for being with us today.
So for you guys too on the call that you don't always get a direct line to a neurologist, let's pivot a little bit. And we've heard a little bit about what this is going to look like. But for Carol and Nevin, as adults now, you guys have been living with this condition for quite a long time. What what do you want to see? What would be most helpful for the patient besides just having everything under one roof and maybe within a 2-hour driving distance of your home, which could be, you know, very tough to come by. But if finances aside, what would you like to say directly to Dr. Nick and people that are listening right now about what a center should look like from the patient perspective? I don't know if Nevin, you want to go first? You've been quiet for a while.
I think the big thing for me is the neurologists typically know a lot about the disease. And if they don't, I think it's better to specialize what we're talking about in specific diseases versus generally practicing on, all neuromuscular diseases. Also, to that point, my pulmonologist and my cardiologist that I have, they have a vast knowledge in Becker and other forms of muscular dystrophy. And the reason why I'm currently not seeing every doctor under one roof is because I've come up with these doctors on my own over time, and I'm not going to leave them because they understand why I'm there. If I was to go to a
Mhm.
regular doctor down the street for my heart, and I did that once when I was transitioning, they asked me, "Why are you here? I don't need to see you. Have a nice day." I said, "Nope. I'm going to drive an hour and a half to go see the doctor that understands if my heart goes and I'm not aware of it ahead of time, I'm in trouble." And
Mhm.
all the doctors under one roof need to understand the importance of these diseases, the importance of getting patients in as early as possible. Because a lot of times, especially with Becker, because there's such a wide spectrum, people don't realize they have it or know what care they need because these doctors aren't educated in it. And then it's too late and they already have cardiac failure. And we don't want them to get there at that point. We want to get them in as early as possible and have all the doctors there that understand why you need to be there, and getting a clean bill of health isn't, oh, wait, you don't need to come here. It's thank you for coming in, come back in 9 months. So the education portion of it is very important to me.
That's an excellent point. And I think we've all known, even the audience in this call, we've all known doctor's appointments where we probably know a little bit more than the person sitting across from us. And there's all kinds of red flags, especially if they're not really willing to be open and listen. And then you wonder about, their training, or you start to say, well, maybe I'll find someone else. The other thing too, and we can talk about this on a future call, is we all know from being in the medical system, every human being alive today, we all deal now with these patient portals, which are great when they work and if they communicate with each other. For those of us living with these chronic rare illnesses, I have maybe 6 or 7 different portals. And depending on which software company has written the portal, they refuse to talk to the other portals. So I'll go somewhere and a pulmonologist will say, oh, you're switching over here, but you had your last pulmonary function test 2 years ago, but I can't see that because I can't get into that portal. So can you go and print it? And, and we were told, oh, we're going to have all these electronic health records. It's in one place. Your whole thing will be accessible to everybody, but they don't always speak to each other. So I would throw that into the mix too. But Carol, what about you? What does the ideal situation look like for an adult living with a rare condition such as limb-girdle?
For me, one of the most important aspects would be more synchronized or coordinated care, making sure that my specialists are connected, they're sharing their notes. They can anticipate when issues may be developing due to my weakness, and they work together to put together a treatment plan for me. I know that with rare diseases, we're often the unicorn in that community practice, where with going to a center of excellence, I wouldn't be the first LGMD patient they saw this month or this week or maybe even this year. Having that knowledge base behind them is something that's really important for me. And sometimes knowing that there's not a lot that can be done to stop the progression of my muscular dystrophy, it's important if they can work with me to help improve quality of life, keep me as independent as possible, reduce risks of fall, monitoring mental health, um, making sure that there aren't any medication interactions, helping me to connect with any specialist that I need to, um, all with the goal in mind of helping me live the best life that I can. So if it's a referral for PT to help me with stretching, range of motion, or if it's at a point they need to make a referral to pain management or talk to someone regarding nutrition, mental health, that's all important for me. Working with whole person care, I think is vital.
I love that because we've spent a lot of time on this podcast talking about medical care, and it is definitely cannot be overstated about social, emotional, and mental health too, because we all know that we're living with a chronic condition that is progressive. So how we live is as important as why, and we need to work both of those things out. And that's another whole aspect of a clinic that I think is important. Um, Dr. Johnson, I don't know if you want to say a few words about that too, about the limb-girdle centers. How will they address things besides the medical care with a nod to quality of life and all the great things Carol just said?
Yeah, I think that's often and both an underappreciated and overlooked aspect, and it's critically important. So I mean, I can tell you that in our clinic we do have a social worker that provides access and support, to both support groups as well as direct care. And more recently, we've added a rehabilitation psychologist to help with coping skills and strategies, which is incredibly important because I think we're all working with the hands that we've been dealt, and so to some extent, kind of improving that mental flexibility around where you are at this moment in your life is just super important. So I think those are some pieces that are worth thinking about and bringing into play.
I love that you mentioned that. And Kat, I'm going to turn over to you in a second. I want to state too that I think a lot of people on the outside that don't live with this, they see us as successful functioning adults and they just assume we have it all together. And that's not necessarily true. And behind the scenes, there are days that we fall apart. And there are the reason why we lean on this community so much with each other and seek professional help when necessary. I mean, it's they just I think a lot of people assume, wow, they have it all figured out. And Kat, I heard you laughing because nobody ever has it all figured out, right? But it's I love that what you just said, Dr. Johnson, about mental flexibility. It's we can't all always handle it all the time every day. And we're talking about these clinics, but there's all these other pieces that make up the whole person. And to Carol's point of, treating the human being first and the medical condition second. Kat, I know you were going to jump in with a question.
Oh, yeah. Well, I was just thinking about what you were saying about, Dr. Johnson was saying too about the mental health aspect of all of this. And we struggled, I think most of us would say in just life trying to put all these pieces together. And I was also thinking of something, what we've got to get people back into clinics. I think, one of the things that I heard already today is I go outside of the system to get this care. And we honestly think about drug development. And when we have treatments that are available, if patients are not in the clinic, they're not going to hear about the treatments, they're not going to receive the treatments. And this becomes like a big issue with drug development and making sure that patients who are with the disease are actually going to see their neurologists and their clinicians once a year. And if the clinics aren't meaningful to them, they're not going to go.
Yeah,
And
they're not going to go back. Yep.
they're not. And so like this is like a call to all industry and drug developers that if you think that this isn't an important thing, you are completely wrong because this is where patients actually go to hear about updates. That's where they go to the clinicians to get treatments. Their primary care doctors are not going to know about this
Yep.
information in a rare disease condition.
Yeah, no, you're right. They got to keep us coming back. That's a perfect pivot to wind up here because I know we're getting short on time. But for all of our guests today, Dr. Johnson, Carol, and Nevin, talk a little bit about maybe we can end with a little bit of a vision here. What do you think? Of course, we're all waiting for the magic sauce, right? And somebody's going to fix the protein and we're all going to run a marathon. That's great. But while we're waiting for that, over the next 5, 10 years, how can you see what do you envision for the clinic space? Again, let's pretend for a minute money is no object, and let's pretend for a minute that we are able to deal with the whole person in a time constraints that don't matter either. What does it look like 5 years from now, 10 years from now? Maybe we'll start with Dr. Johnson. What do you think it will look like if we are able to build this out?
Yeah, I think one of the things, and just to tie some points together, um, when we talk about kind of fracture care, your neurologist at the head of that clinic is also an ambassador for the disease within the medical profession. And so one of the things that I would love to see happen, particularly with additional funding, is that we go to our cardiology department, pulmonology department, et cetera, educate them on these diseases, find somebody who can connect with that. And then you've now grown somebody who's passionate about these conditions as we are. So I think that's one of the things that's important is, these large clinics that can be well supported do provide an opportunity to bring more providers into the space and create knowledge within that clinic. And so I think that's one important thing. And then I am optimistic that over 5 to 10 years, we're going to have at least a few special sauces around to kind of
Love it.
help build and develop that clinical care.
I love that. I love all that answer. So, and Kat and I have gone for 40 plus minutes on this podcast without saying anything funny or making a joke. So I'm going to break that by going to Nevin now. And Nevin, your vision of clinics in 5 to 10 years without New York sports fans, because I'm from Boston, you're from New York, and we have very different ends of the spectrum. So we'll keep our sports rivalry out of this.
Yeah.
But besides having a New York sponsored clinic, what does it look like, buddy?
My vision is one, more doctors. A lot of clinics do not have enough doctors to see all these patients, and that is a big starting point. Two is the education of these doctors, that they understand the importance of these diseases, and they're pushing us to come to clinic, to be there and to be seen by all disciplinaries. Right now, it comes across that, we're the ones that need to dictate our care and force our way, into these clinics. There's not a standard of care for all of us to be there and to be, checked like a car mechanic would check a car at a 5,000 mile service to make sure that everything's up and running. So it goes for another 5,000 miles. So in closing there, it's making sure that we're getting the care so we can run and live our best lives possible.
I love that. Carol, what about you? 5 years out, 10
Uh,
years out, what's it look like?
I would love to see more centers of excellence scattered throughout the United States, so that they'd be easier to access for our MD community. And obviously, through that care, I'd love to see, besides that special sauce, um, slower functional decline, fewer hospitalizations and complications, and I guess overall just a better quality of life, because complications would be caught early and the care would be coordinated and easily accessible.
Well, I want to say thank you again to everyone for being on our second episode. And we will have episode 3 coming up in a few weeks, and check back then. And thank you, everyone. Thanks, Pat.
Thanks, Kat, and thank you to our guests, Nevin, Carol, and Dr. Johnson, for sharing your knowledge and insight. Again, if you're a listener living with muscular dystrophy or working in a clinic, we'd love to hear how you're doing and designing care with patients. We'll provide information along with this podcast so that you can reach out to the hosts and the guests if they're okay with that, because we always want to keep the discussion going. We want this to be a starting point, not an ending point. So thank you again to our guests for their time today, and thanks, Kat.
Thanks, Pat.